So to cap off our entire discussion about chronic kidney disease, it's worth mentioning, how we slow the progression of a patient's chronic kidney disease. So, and just to clarify, really the whole CKD discussion is referring to pre-dialysis patients with chronic kidney disease who you'd be seeing in the clinic. And so, obviously, CKD as a term is sort of a collective term for any patient with a reduced GFR due to a multitude of different causes. And so basically, what are some of the recommendations you would have for all patients, sort of irrespective of what caused the CKD? So number one, so therapy to slow the rate of progression in CKD, independent of the underlying reason, is centered on getting the blood pressure to goal. So first, what is that goal? So especially based on the most recent ACC guidelines, 2017, a systolic of less than 130 and a diastolic less than 80 is the recommended blood pressure for patients with CKD and even diabetic patients. I know there's a lot of goals out there and a lot of separate guidelines, but I think this is a good number to apply to your diabetic and non-diabetic patients. Next, in our patients who have proteinuric kidney disease, they need to be on a RAS blocker, so either an ACE inhibitor or an angiotensin receptor blocker. Not both. We don't use both of them because of the increased risk of adverse events, but one or the other. And the goal is to decrease proteinuria. So, a general goal is less than 1,000 milligrams of protein excretion per day. As low as possible is great. Obviously, some patients have severe nephrotic syndrome and they spill a lot of protein. So if you can't get it less than 1,000 milligrams per day, at least a 50 or 60% reduction is pretty good. Next, in one of the other videos, we talked about protein restriction and how, a modest protein restriction has been shown to reduce glomerular hyperfiltration and also reduce proteinuria. So if a CKD patient is interested in reducing animal protein intake and focusing on, high quality proteins like plant-based proteins and dairy, a modest protein restriction can be beneficial. Also, many studies have shown that smoking actually is associated with progressive nephrosclerosis. So in a patient who's currently smoking, stopping smoking is associated with a slower rate of progression of their CKD. So in all of our patients with CKD, we should be screening them for tobacco use, especially smoking. And if they are smoking, we need to tell them this, that their CKD will progress more slowly if they're able to stop smoking. And this may give them just, another reason to consider smoking cessation. Next, just simply correcting metabolic acidosis that's associated with CKD has been shown to slow the progression of chronic kidney disease. So we can do this with alkali therapy. So as long as we keep the bicarbonate in the normal range, so, greater than 22, somewhere just between 23 and 29, has been shown to slow progression of CKD. So this is relatively easy to treat, and I feel like it's something that's underutilized by many providers. So correcting metabolic acidosis can slow progression of CKD. And of course, last but not least, good glycemic control is related to the rate of progression of CKD. So especially in our diabetic patients, this is important to tell them that the rate of change from microalbuminuria to albuminuria and proteinuria is linked to how well controlled their diabetes is. And so it is important to try and explain to patients the interplay and how different things are linked together. So diabetic and glycemic control is related to CKD for patients with diabetic nephropathy. So here's a sample assessment and plan, like the note that I would write for a patient with chronic kidney disease. And of course, every physician writes their own notes differently and has a different approach. This is just my approach. But up here at the assessment and plan piece, this is where I'm writing about what I think is going on, maybe any clinical history, sort of the one-liner. And then, first, I think about any diagnostics that are needed for the CKD. Remember, first, we like to understand what we think caused the CKD or what is currently causing it, and we want to rule out other things. And so some of the diagnostic tests, include a renal ultrasound. So if a patient has not had imaging of their kidneys, we typically want that. You may find polycystic kidney disease or some other structural kidney disease. You may find kidneys that are full of kidney stones. You may find a patient who has a solitary congenital kidney. I don't know, we just like to get imaging to rule out any sort of anatomical cause of CKD. And so any other diagnostics that may be needed, if the patient has hematuria and I'm worried about a GN, I order certain labs. If I'm worried about proteinuria, I order another set of labs. Next, obviously, I mentioned we're interested in blood pressure. So talk about what medicines I'm using to control blood pressure if I'm starting something new. Volume management. If the patient's hypervolemic, I'm probably starting a diuretic, and so I'm going to talk about that in this section. So in the proteinuria section, I talk about how I'm checking the albumin to creatinine ratio. Some people check the protein to creatinine ratio, but it's just in this section I like to think about, what is their degree of albuminuria or proteinuria? Do I have them on an ACE inhibitor or an ARB? And so I have this whole section devoted to that. As far as metabolic acidosis and electrolytes, I usually say something like, today I'm checking their potassium and their bicarbonate, but most importantly, I want to keep track of the bicarbonate because I want to keep it normal. And if if it's low, then I talk about how I'm supplementing it with alkali therapy, probably sodium bicarbonate, 650 milligrams 3 times a day, and I want to keep the bicarb above 22. Okay. Next, bone mineral metabolism. I'm talking about how I'm checking, PTH, checking the phosphorus, checking vitamin D, and then if anything's abnormal, then I talk about my management plan, whether it's dietary phosphorus restriction, supplementing vitamin D, or starting a phosphate binder or something else. For anemia of CKD, this is where I talk about how we're checking, the hemoglobin, and we're checking iron stores like the ferritin and the total iron binding capacity, right? And so based on these parameters, I can determine whether the patient needs oral iron or IV iron or even ESA type of therapy. Next, I do have a section on the risk of kidney failure progression. And then so as of right now, we have this website, kidneyfailurerisk.com, that uses a validated scoring system that includes age and region of the country, and you can input the patient's current estimated GFR as well as their current albumin urine excretion. And so you can input these values, and it gives you at least a rate of progression, so to speak. So it tells you what's the chance this patient will require renal replacement therapy in 2 or 5 years, and it gives you some percentages. Of course, no calculator is perfect, but it gives you a range, obviously, and this is a place where you can start discussions with your patients. So I do this in front of the patient with them in the room, and so it generates a lot of important discussions, such as, what is the renal replacement therapy plan, and have I sent them to an education class or not? And so overall, this is where I talk about dialysis planning, referral for transplant if I think they're a transplant candidate, and even conservative care, conservative therapy options if that's something that I think would be reasonable. And so obviously a section for disposition when we're going to see them for follow-up. And so, like I said, there's many different ways to come up with a CKD assessment and plan. This is the one I use. I kind of like it, but you may come up with one of your own that you like better. Supported by the William and Sandra Bennett Clinical Scholars Program and the American Society of Nephrology.